vascular disease. In the third world, we say this is a poor man's cardiac catheterization. If the ABI is low, that patient is very high risk. And it is 95% sensitive and 100% specific. It is better than pap smears, stool guaiacs, mammography. So a very simple and a very effective and very easy test. And also, if your ABI goes lower, the greater your risk. And also, if your ABI goes higher, the more calcified your vessels, the greater your risk of a future cardiovascular event. Okay, 53-year-old man visits you 1 month after discharge from the hospital for unstable angina without heart failure. He was found to have severe stenosis of the mid-right coronary artery that was stented. He also has a history of hypertension and diabetes. A renal ultrasound was done prior to his discharge because he's on 3 antihypertensive agents, which revealed a severe stenosis of the left renal artery. His blood pressure is 126/74, and his heart rate is 70 beats per minute. Which of the following is the most appropriate recommendation for this patient? CT angiogram to confirm severity, schedule angioplasty or stenting, schedule angioplasty, stenting since the patient is on multiple antihypertensive agents, no intervention needed. Excellent. No intervention needed. Now remember, this patient today at the visit has a normal blood pressure. You do not need to intervene even if the patient is on multiple antihypertensive agents. You do not need to intervene. The only indications to intervene for renal artery stenosis if the blood pressure remains poorly controlled. If they have worsening renal function, the creatinine keeps getting worse, then you want to go in and stent it to improve flow. Flash pulmonary edema or heart failure and unstable angina. If a patient keeps getting admitted with heart failure and you can't understand why, think about renal artery stenosis. The way it works is your normal blood pressure is about 120. If you have a renal artery stenosis, there's not enough blood going to that kidney. So the blood pressure in that kidney is about 60. And the kidney says, my blood pressure should be 120. So it releases renin. Renin causes salt, aldosterone, and then that causes salt and water retention, and the patient keeps going into heart failure, unstable angina. So it is only for uncontrolled hypertension, CHF, that you think about stenting of the renal arteries. If the patient has 3 or more antihypertensives and the blood pressure is controlled and the renal function is not worse, the patient does not need intervention.
If you fix the renal artery, wouldn't you possibly be able to take him off of the medication?
There's no data to indicate that. No data. It's all, and you know, when you find renal artery stenosis of about 70% or more, it's only when you catch it initially that you're going to make a significant benefit. If that renal artery stenosis has been there for a long time, the baroreceptors have been reset, and it's very difficult to then reduce. But I'll tell you this, I have seen in the recovery room, after I've stented both renal arteries, and they call me that the patient is hypotensive, and you go in and you're examining the groin and you're looking for a retroperitoneal bleed and you can't understand, it was because we stented both renal arteries and suddenly the blood pressure drops significantly. But no outcome data. So that oculostenotic reflex for interventionalists to stent renal arteries is not quite recommended. Am I at 4.4 or 4.5? I think 4.5 again. Okay. 76-year-old man with chronic asymptomatic occlusion of the left internal carotid artery. Comes in with transient left arm weakness. Because of non-compliance, he's on no medication. His carotid ultrasound revealed that he has a chronic occlusion of the left internal carotid and a 60 to 79% stenosis of the right. Which of the following is the current recommendation for this patient? Medical treatment since he was non-compliant, aspirin and a statin, urgent referral for carotid endarterectomy, urgent referral for carotid artery stenting. Is it recording? Okay, this is the reason. If you have one carotid artery occluded and you need intervention on the other side, carotid artery stenting is recommended by the guidelines. Because the vascular surgeon will occlude it and you don't want to occlude it, so carotid artery stenting is preferred over carotid endarterectomy. And all the trials, by the way, show that carotid artery stenting is as efficacious as carotid endarterectomy. It's just the pushback we're receiving from the surgeons. But there are certain indications for carotid artery stenting. Remember, if a patient comes in, generally, when a patient has a more than 80% stenosis, that's when we recommend either carotid artery, and the guidelines still say carotid artery surgery, carotid endarterectomy. But if one artery is occluded, then it's carotid artery stenting. If the patient already had surgery, then the next time around it's carotid artery stenting. So more than 80%, that's when it's recommended. But if somebody's had a TIA like this patient, then more than 60% one should recommend revascularization. Because if somebody has a TIA or a stroke, they have a 9 times risk of having another stroke. 9 times. So it is very important that this patient has carotid artery stenting. These are the current indications for stenting. If they have a diminished ejection fraction, if they have heart failure, if they have unstable angina, if one side is occluded, recent MI, if they have recurrent restenosis, if they have prior radiation, or if they have COPD and other conditions that makes them high risk, then carotid artery stenting is preferred over carotid endarterectomy. A 38-year-old woman is being evaluated for 2 syncopal episodes. The first 18 months ago and the second 5 months ago. She describes an uneasy sensation preceding these events, but no palpitations, no chest pain or incontinence. Her EKG, her stress test, and her echo were unremarkable. Her 24-hour Holter monitor followed by a 30-day event recorder did not reveal any arrhythmias, but the patient did not have any symptoms during that time either. She's a school bus driver and takes no medication. Which of the following is the most appropriate testing option? Repeat the event recorder, loop recorder, cardiac cath, no further testing at this time. Excellent. Loop recorder. This patient, the risk is very high for an arrhythmia. She has an uneasy sensation. She's passed out. The 2 episodes of having syncope, one 5 months, one 18 months. If we repeat a 30-day event recorder, it's unlikely we'll find her arrhythmia. So an implantable loop recorder. This is about the size of a flash drive. It's placed under the skin subcutaneously. It's under local anesthesia. It takes about 5 minutes to do. It has a battery life of about 3 years and can store arrhythmic events or cardiac arrhythmias for up to about an hour. So a very useful, very easy device that is beneficial in these patients. Okay, 5-3. That's a very good question. Okay. All right, we finished this. You have to individualize treatment. A 76-year-old woman with a history of hypertension and diabetes requests a follow-up. We only have about 5 minutes, guys. She wishes to discontinue her warfarin because it's too much of a hassle. Haven't we heard that before? She has a history of paroxysmal atrial fibrillation, denies having any symptoms, no history of a DVT, TIA, or stroke. She's currently in sinus rhythm. The patient's risk of a thromboembolic event of anticoagulation as compared to a patient with permanent atrial fibrillation is less, the same, or higher. This patient has paroxysmal atrial fibrillation. I would have thought most patients would have said less. It's the same. So if somebody has paroxysmal atrial fibrillation, do not withhold anticoagulation. Even if they have only occasional AFib, the risk of a stroke is the same as that of somebody who has permanent, persistent, or paroxysmal atrial fibrillation, and the patient needs anticoagulation. A 66-year-old male schedule an appointment to see you. He has no medical problems, takes no medication, feels well and exercises regularly. He smoked for 16 years but quit 30 years ago. His father died at age 76, cause unknown. Blood pressure is great. Lab data, his total cholesterol is 160, HDL 45, LDL 98, and his Framingham risk score is 9%. So here's an asymptomatic guy who quit smoking 30 years ago. Which of the following would you recommend? Aspirin, stress test, echo, abdominal ultrasound, do nothing. Abdominal ultrasound. Okay, the patient's Framingham risk score is 9%. The patient does not need aspirin or a statin. They're low risk. The U.S. Preventative Task Force now recommends as a core measure that all men aged 65 to 75 who have ever smoked, ever, a one-time screening of an abdominal aortic for an abdominal aortic aneurysm. This is the commonest diagnosis that is missed. Runs in immediate family members and occurs in men who smoke, so 65 to 75. The machine nowadays to screen for this, and the guy is still out there, I asked him to wait, is smaller than an EKG machine. Medicare reimburses about $90, and it takes less than 2 minutes to do. But you can make a significant difference if you diagnose an abdominal aortic aneurysm. And there are other indications, hypertension, etc. But If the patient ever had a history of cigarette smoking, that patient needs to be screened for an abdominal aortic aneurysm. Okay, a 63-year-old woman requests to see you for a second opinion regarding anticoagulation with warfarin for paroxysmal atrial fibrillation. She is currently in sinus rhythm, but does complain of occasional fluttering, which bothers her. Her only other medical history is significant for hypertension. Physical exam, blood pressure is 142/776. Your second opinion to her is continue warfarin, discontinue warfarin and start one of the new direct 10A inhibitors, Pradaxa, Xarelto, or Eliquis, discontinue warfarin and start aspirin, discontinue warfarin and start an antiarrhythmic. Okay. Discontinue warfarin and start aspirin. Now, to know this, you use what we call the CHAD score. This is a stroke risk calculator. And if a patient has a history of congestive heart failure, they get 1 point. Hypertension, 1 point. If the age is more than 75, 1 point. Diabetes, 1 point. And if they have a stroke or a TIA, a history of, they get 2 points. So if you look at our patient, she is 63. Her only risk factor is hypertension, so she has only 1 point. This here tells you that if a patient has a score of 0, they're very low risk. Therapy is aspirin or nothing. If the patient has 1 point, as our patient, they're low to moderate risk. This should be low to moderate. Aspirin or anticoagulation, and you can discuss the risk with the patient. If the patient has more than 2 points, the patient needs anticoagulation. Now, what is very important is that the guidelines now are insisting that we use the CHADS VAS score. Just this month, just 2 days ago in Cardiology Today, they pushed this. Now, there's a little typing thing here. Under CHA, after A, there should be 2. The letter 2, just like there is after S. So basically what they're saying, and I checked with a number of electrophysiologists, they're all using the CHADS VAS score. So it's still C, congestive heart failure, 1 point, H, hypertension, 1 point, A, age more than 75, 2 points. D, diabetes, 1 point, prior stroke or TIA, 2 points. If you have any kind of vascular disease, peripheral arterial or carotid disease, 1 point. If your age is more than 65, so they said 65 to 74, 1 point. And sex category, 1 point, if they are a female. If you're a female, 1 point. Now it's interesting, if you look at this CHADS VAS score, it means that if you're a female, automatically you have 1 point, just because of your sex category. But they still showed that under 64, the risk of a stroke in women is very small. So they're pushing the CHADS VAS score to include more risk factors and to significantly lower the patient's risk of an event. Okay, final question. This is going to carry a lot of points. A 70-year-old man with a history of tobacco use sees you for a routine follow-up visit. You have learned at the 7th Annual Cardiovascular Conference that the U.S. Preventative Task Force recommends an abdominal ultrasound in men 65 to 75 years of age who have ever smoked. You order an abdominal ultrasound which reveals a 3.9 centimeter abdominal aortic aneurysm. He would like to know from you, when do you anticipate his repair will be needed? Okay. Approximately 6 years, and I'm going to get into it in a second. Repair for abdominal aneurysm is recommended at about 5.5 to 6 centimeters. In Europe, it's 6 centimeters. We're moving away from 5 to 5.5 to 6 centimeters. But you've got to want this patient to have a life expectancy of about at least 2 years before you subject this patient to this very high-risk operation. So 5.5 to 6 years, or unless it is expanding very, very quickly. How do you monitor these patients with abdominal aneurysm? Is it less than 3 centimeters? 5 years. If it's less than 3.5, 3 years. If it's less than 4.5, 1 year. And if it's more than 4.5, 6 months, every 6 months. So let's take our patient now. An abdominal aneurysm grows at the rate of 0.3 centimeters a year. So this patient is 3.9. So in 1 year, it's going to go to 4.2. In 2 years, it's going to go to 4.5. In 3 years, it's going to go to 4.8. In 4 years, it's going to go to 5.1. In 5 years, it's going to go to 5.4. And in 6 years, it's going to go to 5.7. So it grows at a rate of about 0.3. If it goes faster than that, so that is when this patient will require the abdominal repair. Now, we tried this for the first time, and I hope it was beneficial. I don't know, but it is important for you to turn in your evaluations so that we know who we should bring as speakers and what we should do for our future events. This was a trial. I hope it was beneficial, and I hope we'll see you next year.